Today, I am dealing with two aspects. In fact, it is a single aspect, that is the physiological basis of a pain treatment. In this physiological basis of a pain treatment, the gate control theory of pain assumes an importance. The gate control theory of pain was proposed by Meljack and Wall in 1965. Before that, the pain was considered as a specific modality and a specific the specificity theory was proposed. And these two scientists, they proposed the pattern theory, and they gave certain explanations. They explained certain phenomena associated with the pain, and it was very well acclaimed. Later on, this Meljack and Wald, they reviewed and revised their own theory somewhere in 90s, and then they amended to the first proposal. Anyway, I am just trying to, here are the pictures of these great persons. This is Meljack and the Wald, and they have contributed a lot. Of course, there are many more scientists who have contributed a lot to the pain understanding. Let me start the lecture by defining the pain again. It's an unpleasant sensation or a sensory and emotional experience associated with actual or potential tissue damage or injury. The pathways for pain include epicritic pathway, that is the discriminative pathway, and proteopathic pathway, the non-discriminative, that is affective, and reticular pathway. The epicritic pathway starts with the receptor, the pre-nerve endings, carried by the C fiber and A delta fiber, reach the dorsal root ganglion and the dorsal horn neurons, the layer 1, 2, and 5. From the layer 5, the projecting neuron will cross to the opposite side and ascend as a lateral spinothalamic tract. And this lateral spinothalamic tract concerning with the epicritic pain is neospinothalamic tract. And of course, it gives collaterals to the rostroventral medullary neurons, the reticular system, and the periaqueductal gray, and in the parabrachial nucleus. These neurons relay in the ventro-posterior-lateral nucleus of thalamus, that is a specific nuclei of thalamus, and then they are relayed into the somatosensory cortex, postcentral gyrus, S1 or Broadman area 312 for identification of the location and the characteristics of or attributes concerning with the pain. In case of a proteopathic pain, this is carried by the paleospinothalamic tract. The paleospinothalamic tract, as usual, from the receptor, the nociceptor, to the fibers, fibers carried by A delta and the C fibers, they will come and relay in 1, 2, and 5, and the projecting neuron ascend to the thalamus via parabrachial nucleus, via parabrachial and reticular nuclei, parabrachial and reticular nucleus. So the parabrachial nucleus, of course, is connected with other components of the brain areas. And These lateral spinothalamic tract projections as a paleospinothalamic tract reach the dorsomedial nucleus of the thalamus. This dorsomedial nucleus of the thalamus is relayed into the cingulate cortex. This is cingulate cortex here. And it also relays into the ventromedial posterior nucleus of thalamus that is relayed into the insular cortex. So these parabrachial outputs, they project to amygdala, hypothalamus, cingulate, and insular cortex. I mentioned about these insular cortex and the cingulate cortex for the ultimate processing of the pain. This is about the emotional or affective component of the pain. The first one was the discriminatory component. The second one is a proteopathic component, that is the affective component. Then the behavioral responses in response to the pain are originated by the cingulate cortex and insular cortex through consultation with the prefrontal cortex, and whatever the response is mediated through the hypothalamus or autonomic nervous system. Also, the parabrachial nucleus is a part of the reticular system in the medullary and the midbrain level, and that will also project to the non-specific nuclei of the thalamus, that is for the arousal response. Third component of the pathway is the spino-reticular pathway. The spino-reticular, this is from the spinal cord, the nociceptor, they come here, they are they relayed through the dorsal root ganglion. The diagram is not very perfect here. It is coming through the dorsal root ganglion, and then they cross to the opposite side, layer 5, layer 1, 2, and 5. Layer 5 contains the projecting neuron, and this will cross and ascend as a lateral spinothalamic tract. This is a lateral spinothalamic tract. So this lateral spinothalamic tract reach whatever the sites as a neospinothalamic or paleospinothalamic, and in between it gives a collaterals to the rostroventral medulla. This rostroventral medulla, it forms the reticular system, and this in turn projects to the thalamus independent of this pathway, a reticulothalamic pathway. Reticulothalamic pathway reach the non-specific nuclei of the thalamus for arousal and attention response. In addition, this reticular pathway project down to the spinal cord as a reticulospinal tract, and this reticulospinal tract is excitatory to the substantia gelatinosa cells. That means from layer 1 and 2, the substantia gelatinosa cells originate, and they make a synaptic contact with the layer 5 neurons, the substantia gelatinosa cells, for the inhibition. In addition, these reticular networking that will stimulate the medullary autonomic centers and the respiratory centers and the cardiovascular centers. That is about RVM relay. Then the relay in the midbrain in the periaqueductal area, and this periaqueductal area, it will be relayed, and these relays these are in turn project to the rostroventral medulla via dual pathway. One is adrenergic, another is serotonergic. And these in turn project onto the spinal cord. So these periaqueductal neurons receive input from reciprocal contacts from the amygdala, the hypothalamus, the cingulate cortex, the insular cortex, and the prefrontal cortex. That's what I have written. Have a reciprocal connection with the cingulate cortex, the prefrontal cortex, the hypothalamus, the amygdala, and the which governs pro and anti-nociceptive actions. Because a pro-nociceptive action means it will it will take into a chronic staging of the pain. Anti-nociceptive is it releases the encaphylinergic excite the encaphylinergic neurons that will suppress the pathways either at the thalamic level or from the hypothalamus to the cingulate and amygdalar areas. In addition, they will send a descending inputs which would suppress or which will excite the substantia gelatinosa cells to inhibit the transmission further. That is about the spino-reticular relay. Now, after seeing the pathways, because I am always taking the pathways as a part of the system, so that revise you at least three times, so that you will have an idea about the pain pathways. Now, what are the various pain management strategies? I am bringing back the yesterday's previous day's figure here. Here it is the processing figure I have made, processing at various 11 areas. This 11 areas, just I am trying to, the management would be happening at all these 11 areas. But for my practical considerations, I have categorized into practically the 7 areas. In fact, it would be maybe 4 or 5 areas. This is the local treatment is one area, the nerve is the second area, the spinal cord is the third area, medullary and periaqueductal is the fourth area, thermocortical is the fifth area. That is how we can divide the pain management strategies primarily in 5 different areas. So now, what happens? This is a local one at the receptor where there is a cut or an injury or something, inflammation, all these things. How we manage this pain, or what is the treatment for that pain? Now, you just look at that. This is the receptor here, and what the site of pain, usually the local treatment. Rubbing and massaging, gentle rubbing and massaging. Yesterday I was trying to describe about it, the massaging effect, try to make or diffuse the nociceptive chemicals or inflammatory chemicals released into the blood, and they will push into the circulation. That is a flushing effect. So that is gentle massaging that will remove the excessive cell degradation products and the inflammatory products. They will all be removed. That is rubbing and massaging that will relieve the pain. At the same time, even accumulation of fluid itself produces the stretch that also will enter into the blood vessels. So that is how it relieves, by diffusing the chemicals, one, by decreasing the stretch because of the edema or the fluid accumulation, and that is how it relieves the pain. That is one part. That we always do. Whenever there is something, we try to do that, and we try to, if I am saying, we try to continuously or constantly touching the part gently and making a gentle massage, so that it is a natural phenomena to drain the excess fluid and excess chemicals. Then application of counter irritants. The counter irritants, maybe the southern part of India, we have Amritanjan, and the Vicks vapor, that is menthol containing balm. Or if you go to the Southeast Asian countries, it is the tiger balm. And some of these counter irritants even contain capsaicin, menthol, capsaicin, and these combination, what they do, they irritate. They will produce the irritation of the local sites. Thus, they desensitize the nociceptors and the nociceptive fibers. So the application of the counter irritants, maybe you must have used these counter irritants for your headache. So the application of the Amrutanjan balm, I don't know whether you are aware of that. The Amrutanjan or counter irritant balms. That is one part that would desensitize the local parts or local receptor level. Then another aspect is cooling. That means you cool down. You put a icicle or a cube of ice. And this cube of ice cool down the receptors as well as the nerve fibers and decrease the discharges or the excitation or their threshold will be raised so that they cannot be easily excited, so that would produce the cooling effect. Or apply the local anesthetic so that at the first node of Ranvier or at the first point where the local generator potentials are originating, they would be blocked, local anesthetics. Or use anti-inflammatory drugs. Any anti-inflammatory drug, we have a paracetamol, aspirin, indomethacin, or any other non-steroidal anti-inflammatory drugs. What they do, they will reduce the inflammation so that whatever the inflammatory chemicals of the prostaglandins and cytokines which are produced, they will be, especially because most of these non-steroidal anti-inflammatory drugs are the inhibitors of the prostaglandin synthase. So that means prostaglandin is synthesis is prevented, and the prostaglandin is an inflammatory mediator, and by that the number of other chemicals are released. So that means that would block one, reduce the inflammatory chemicals. Point number 2, that would reduce the edema by doing so, and by reducing the edema, the stretch is reduced. Thus, they will relieve the pain. So that means, as such, they have an analgesic effect, and this analgesic effect is coming from analgesic and antipyretic effect. They will reduce the temperature at the higher level. That means they will set point level in the hypothalamus, and the temperature is monitored, the stretch is monitored, the stretch is decreased, and inflammatory chemicals which are mediating, they are reduced, so they will help to relieve the pain. So that means these anti-inflammatory drugs, they would help at the local level. Then of course they have actions at other sites also. I'm not disputing that component. Then we have what we can do for the nerve fiber treatment at the nerve fiber level, because from the receptor it will reach to the dorsal horn neuron through the nerve. So now what we will do, the cooling, that means cool the nerve segment, maybe somewhere here. If you cool down, the number of impulses traversing would be diminished. Or apply a local anesthetic. If you apply local anesthetics, it will block the action potentials, especially if this is the point where I have got the injury, and if I have applied a local anesthetic here, so that means impulses will not reach to the spinal cord and brain. So that means local anesthetic application. Our local anesthetics are nothing but sodium channel blockers. Our application of sodium channel blockers also prevents the generation of the action potential at the nerve terminal. The most severe cases, say for example, in a terminal case of a cancer, where you have some cancerous lesion at a point where the nerve supply is clearly identifiable. So then cut the nerve to the part, the neurectomy, that's cutting. So if you cut, the pain is not reaching. If the pain is not reaching, you would be relieved of the pain. So now this is one part where you can identify a nerve to where it is originating from. say for example, if somebody is having a specific cancerous or any other type of a gangrenous lesion, these things, so then at that point maybe you can reduce that pain, especially the cancer pain, by cutting the nerve which is supplying, because it is only indicated in the terminal stages, because you have no other option to deal with. Then you do the dorsal rhizotomy. What is the dorsal rhizotomy? That means a dorsal root sectioning. Dorsal root you cut where the entry of the impulses into the spinal cord are delayed. So this is about the nerve fiber treatment. I say cooling, local anesthetic, the nerve resection or sectioning, and the posterior root dissection. Because if you do the posterior root dissection, and then there would be associated with a tone loss, because the muscle tone is regulated by the 1A alpha motor neuron activity. If these, because posterior roots, you cannot isolate only the pain fibers, so it becomes real. Again, there is a loss of tone in the muscle supplied by that particular nerve. Then in the spinal cord, we have a number of options. So that is in the dorsal horn neurons. This is the segment where we are trying to look at. So starting from spinal anesthesia, you do the lumbar puncture and inject some local anesthetic agent, so that the impulses in from the spinal cord will not ascend up in the lateral spinothalamic tract. So that will, or use opiates, because in the spinal cord there are opiate drugs, the opiate receptors are there, and even at the point where the projecting neuron is situated in the dorsal horn in layer 5, and from layer 2 to layer 5 there is an interneuron that is encaphylinergic or opiate. So use of opiates will decrease or inhibit the transmission of impulse to the lateral spinothalamic tract. So that is a morphine and morphine-like drugs. Or you can use the alpha-2 adrenoceptor antagonist. Or you can use the GABAergic drugs. GABAergic drugs are the inhibitory, so they will be inhibiting the transmission. Then the people are going for acupuncture and acupressure or a nerve stimulation. This one I will consider in the subsequent slides. And the another surgical interventions like dorsal rhizotomy, chordotomy, sympathectomy, myelotomy, and laser tractotomy. Let us see them here. This is the spinal cord. Dorsal rhizotomy. This is the dorsal rhizotomy. This is where it is cut. Rhizotomy is the procedure of cutting the dorsal root. This is the dorsal rhizotomy. Because you need to go to the spinal cord level and identify the dorsal root and cut it. Or chordotomy. So this is the, say for example, it is generated from this side, on this side, and you dissect out or you cut the lateral spinothalamic tract. You sever the lateral spinothalamic tract. So that means that will not permit the pain sensations ascend up to the thalamus or into the different parts of the brain. That is one thing. You just go there and with a laser or with a surgical, you can destroy these areas. However, you cannot prevent the other segments without. And in this procedure, what you are doing, you are also destroying all the other segments below that particular level. So that means that's another important aspect about the chordotomy. Then sympathectomy, especially if it is some of the sympathetic fibers, they carry the afferents, especially the The sympathetically originated pain fibers are the thromboangiitis obliterans. It's a vascular disease in which it's also known as a Berger syndrome, and in which there is a pain in the lower extremities. And in that case, sympathectomy is performed. The myelotomy, then fourth one is the myelotomy. Myelotomy is a procedure, you cut these fibers, these especially the fibers which are crossing here. Say, for example, it is originating from this side because they cross to the lateral spinothalamic tract. You cut this here. This is the procedure, the central rhizotomy. You cut this thing here. There are nothing there. This posterior root is fine, and you cut it here. And if you cut these are the fibers here which are crossing, do the myelotomy. So cut that. Or there is another thing, because when the pain fibers come here, they will form the Leischer's tract. Leischer's tract, that means 2 segments up and 2 segments down. And this Leischer's tract is in the dorsolateral position of the dorsal horn here, somewhere here. And in this dorsolateral portion, and you cut that tractotomy, the Leischer's tractotomy. Perhaps this is more sophisticated microsurgical procedure in which you have to dissect out these things, only those segments involving those segments where the pain is originating. So this is about the surgical intervention or surgical physiological basis for the surgical relief of the pain. Yes, you imagined right. This is the Tollgate. You have seen or you are acquainted. Of course, this is automatic Tollgate, and a person is having these things and infrared rays, and he will be sending the infrared rays or whatever is the units here. It will be detected. Once it is detected, it reads the tag, and once it reads the tag, okay, it opens up and it opens the gate. It opens the gate. Otherwise, the gate is closed. Yes, we have a similar type of mechanism in our pain pathway. The pain pathway, this was proposed by Melzack and Wall in 1965. Now, let me tell what is this gate control theory. So initially when they proposed, they were looking at the large diameter fibers and the small diameter fibers, A delta fibers and C fibers. Nowadays, this is A beta fiber and thinly myelinated and C fibers or small diameter fibers. Now, when the impulses from the small diameters, they ascend, what they do, they would activate this target cell. This is the target cell which is located in layer 5, lamina 5 of the spinal cord, and this will be ascending cross to the opposite side, ascend the lateral spinothalamic tract. Now, these one will excite these target cells, and the pain is reaching. At the same time, they stimulate the substantia gelatinosa cells present in 1 and 2 lamina. And these substantia gelatinosa cells in turn inhibit the inputs coming from here. I will come back to this thing. Inhibit this phenomena. So that means they keep the gate open. So this small diameter fibers, they will excite the target cells. They will allow the pain to move, and at the same time, they will suppress the substantia or inhibit the substantia gelatinosa cells. And what these substantia gelatinosa cells do, they will inhibit the transmission of this impulse. So inhibition of inhibition, minus. Inhibition of inhibition, that means there is no inhibition, withdrawal of inhibition. So that means the gate is kept open. So this is what. And if the large diameter fibers, maybe these large diameter fibers are A beta fibers, they are not for the pain. They may be for the touch and other sensations, other modalities of sensation. And when they are stimulated, when the large diameter fibers are stimulated, what they do, they would excite here, they will excite for the purpose of touch or anything. At the same time, they stimulate the substantia gelatinous cells in layer 1 and 2. And these substantia gelatinous cells in turn inhibit the path, both sides. You just see here, it inhibits here and it inhibits there. What happens? The gate gets closed. So when the large diameter fibers are stimulated, the gate gets closed. So that means it inhibits the transmission. So this is the gate control theory proposed by Melzack and Wall. I read it for you here. Stimulation of a large diameter fibers. These are large diameter fibers are usually A beta fibers. Transmit pain to the brain. Okay, that's fine. At the same time, they will excite the substantia gelatinous neurons. They will excite, see that it's plus there, substantia gelatinous neurons. And this substantia gelatinous neuron in turn have an inhibitory synapse, inhibitory transmission. They inhibit the transmission here and in turn inhibit the signaling of the T neuron. So that means it inhibits the T neurons and that closes the gate. That closes the gate. That means the pain will not go further. Pain will be stopped here. Whereas the small diameter fibers, these are small diameter fibers, when they are excited, they will send the impulses in the beginning, followed by mediate the responses to the mu and delta opiate receptors. The mu opiate receptors are low threshold afferent stimulation, and delta opiate receptors are high threshold afferent stimulation. I mean to say that this is a low threshold is a large diameter, that is a mu receptors here. There are mu receptors, and high threshold is a small diameter. This is delta receptors of the morphine-like compounds or opiates. This is mu here, and this is delta here. So that means each one, both are inhibitory, but they would either open or close the gate. Now, the conditions that open the gate, I have just mentioned all of them. I will read it for you. Physical conditions. If the extent of injury is large, then the gate closure question does not arise. The impulse traffic is heavy and the gate has to open. The impulse extent of injury is more, it allows the movement. Open the gate. That means pain. The activity level, so that means physical conditions, there is a lot of stretch, lot of chemicals, the inflammation, the infection. So all those things, they further increase and open the gate. Emotional state, anxiety, you are anxious. Yes, the gate is open. It is coming from here. Worry, you start worrying, what happened to it and why did I do that type of thing? So worry, so that means that opens the gate. Tension, the emotional, negative emotion, so that opens the gate. Depression, negative emotion, that opens the gate. That opens the gate. The mental condition, and you always worry about the pain. You look at that, okay, I got it injured and what is happening and it will not be relieved and what. So you keep on worrying. That means you are focusing on the pain or a pain producing the structure. And for this thing, because that is one part, the second part is the prefrontal cortex is coming up, that social aspects, the boredom and the loneliness and lack of a social support system. That means friends are not there, relatives are not there. You get bored, loneliness, and then these negative emotions are activated. So this is all the conditions that open the gate. Now, these are the conditions that close the gate. You just look at that. The physical conditions, that means application of a medication at a local level or at the neural level or at the synaptic level. These medications, These medications may be simple non-steroid antagonists like aspirin, paracetamol, or any other drug. So that will reduce the pain and edema and the temperature and the formation of the chemicals. The massage, gentle massage, that will, I have already said, the move the chemicals and the release the stretch on the wall or whatever, the tissue stretch that would relieve them. Counter stimulation. Counter stimulation is the stimulation, the application of the counter irritants. So the either desensitize at the local level or stimulate at the beta cells here in the gate that would open, that would stimulate these substantia gelatinous cells, and that would close the gate. Emotional states, these are positive emotions. You are unhappy and joyful personality. You just least bother about the pain and you are not bothered about it. Okay, that's the one. And other positive emotions, I was talking about a frontline soldier fighting a war. And for him, winning the war is more important than what the pain is about. Then stress. This is one of the interesting things. During stress, stress releases the pre-opiomelanocortin from the hypothalamus. This pre-opiomelanocortin is a large molecule that is necessary for the release of ACTH or corticotropin. ACTH is a hormone, adrenocorticotropic hormone, also known as a corticotropin. This corticotropin is necessary for the glucocorticoids to be released from the adrenal cortex. Now, that is a stress response. But at the same time, because the stress activates the release of the pre-opiomelanocortin, so that means it releases the opiates also. These opiates produce analgesia. So usually the stress is stress blunts the pain response or produces analgesic response. That's another aspect. So don't think it in the other way. That means to relieve pain, don't produce a stress in your patients. But I'm just trying to see how the stress is producing analgesia. I am trying to give you the physiological explanation. Then relaxed state of mind is a positive emotion that would actually stimulate this and close the gate. The rest, again, a positive emotion stimulates it and close the gate. Then achievement, you are doing something and there is a positive input so that you are not bothered, so it becomes trivial. You say that, come on, let us worry about this thing later on. So those things are the emotional states. Then we have the mental condition. So that means you divert one's reaction to the pain for something else. You get involved in yourself in music, games, sports activity. So then the pain gets reduced. Practically pain remains same. But because of this mental condition, you don't feel the pain. Or preoccupy, you start, that's a preoccupation, I said, the music, sports, and other activities, they will all close the gate. Okay, I have, in these two slides, I have said what are the things which open the gate that produce the pain, that are the things which close the gate that will stop the pain. Now, what are the various descending projections that regulate gate control theory? Okay, the descending projections come from the brainstem, and that especially the periaqueductal from the midbrain periaqueductal area and the retinucleus. So here is a brief summary of that the descending projections. You will see that this is the point, the A delta C fiber, the input, they will activate, and this is ascending up, and this ascends up to the S1, and this is the insular cortex, this is the cingulate cortex, and this is amygdala there, and this is hypothalamus, and this is thalamus. So now this is going through the thalamus to the different areas of the brain, as I have already described. Now this pink part, the pink part is the descending projections. You see that descending projections coming from hypothalamic area, coming from this insular cortex, partly coming from the anterior cingulate cortex, and all these things they descend down. You said just that it's funneling effect. It funnels down. It funnels down and funnels down to the periaqueductal gray. Periaqueductal gray. From the periaqueductal gray, so this will be relayed into the medulla. This is the medulla here. The one nucleus, it is a norepinergic nucleus, dorsolateral pontomesenchymal tegmentum. This is having inputs to the things through the norepinergic neurons. And you have another input from the periaqueductal gray to the raphe nucleus. So this is serotonergic, and that descends down. That descends down here. So that means this is this one will both of them will come here, and they would decrease or modulate the pain. Okay, so now what brainstem, periaqueductal gray and raphe nucleus produce analgesia. That is what I mentioned here. Then prefrontal cortex, the cingulate cortex, the limbic system, hypothalamus, periaqueductal gray, raphe nucleus. So that means prefrontal cortex, and this is the cingulate cortex. This is the insular cortex. Then it is amygdala. This is hypothalamus. All these things funnel down. You just see that pink area. They will come to the periaqueductal gray and then to the raphe nucleus. That inhibits the pain. This is about the descending projections that control the gait. That means the one which is the control system. Control system has a connections with all these parts of the brain. Now, this is what I have mentioned. The periaqueductal gray receives input from the anterior cingulate cortex, the frontal cortex, the hypothalamus, the central nucleus of the amygdala, and all these things, they reach here to the periaqueductal gray. Through the serotonergic projections, they reach the rostroventral medulla, and that descends down to the reticulospinal tract, to the lamina 5 target neurons. And on the other side, through the locus ceruleus and the noradrenergic pathway, DLPT, and then they will descend down to this reticulospinal tract, and they will try to excite either norepinephrine here and serotonin here, excite that large diameter, the neuron in which it inhibits the or closes the gate. Now, the fourth and the fifth, I mentioned the medulla and midbrain in the the levels for the treatment of pain. So this is where I leave the gate control theory. The gate control theory. So if I were there, so it is between the interaction between the large diameter fibers and the small diameter fibers, and these large diameter fibers close the gate. The small diameter fiber stimulation opens the gate, and these large diameter fiber. There are many factors which operate either to open the gate or close the gate, I have mentioned, and this will depend upon the descending projections and the local effects of at the spinal level. And this is what I mentioned. That is about a gate. So now coming back to the treatment strategies using the medulla and midbrain, and usually the medullary stimulation or the periaqueductal stimulation. Suppose if I insert the electrodes somewhere around here and stimulate this raphe nucleus. This is the raphe nucleus. And if I stimulate this raphe nucleus, that would release a tremendous amount of serotonin. This is a raphe spinal neurons or serotonergic, and that would produce a tremendous analgesia, especially they will excite the neurons which release opiates. It's as good as giving a morphine to the individual. So that means it produces analgesia. But the main problem is to introduce an electrode into the raphe nucleus in the medulla, because the medulla is a part where all the vital centers are located. So this proposal is very, very difficult to achieve it, and anything happening may alter the activity of the respiratory centers or the cardiovascular centers. So that means you will be ending up with more problems than what the pain is about. So that is what they, however, that is either activation of these things produce or suppress the pain through the encephalinergic neurons. The here, if you come, this is a little safer than these areas. The stimulation of the periaqueductal gray. So now the periaqueductal gray, so it has an added advantage. It releases morphine-like compounds in the canal here, in the third and fourth ventricle, and that would suppress the activity going up. That's one part, either in the thalamic level or at a hypothalamus level. Now, at the same time, it will send impulses down and activate these catecholaminergic and serotonergic pathway, and that would achieve the same. That means the stimulation of periaqueductal gray activates serotonin and catecholamine, norepinephrine tracts, and that would suppress reaching a non-specific nuclei of thalamus. So that means it will not go, the activity is not there, and facilitate the anti-nociceptive actions of cingulate cortex. In even the stimulation here, this will go to the cortical centers that facilitates the anti-nociceptive actions of the cingulate cortex and the prefrontal cortex, and it suppresses the paraventricular nuclei of the hypothalamus by releasing enkephalin here in the third ventricle and the lateral ventricle, third ventricle and the fourth ventricle. At the same time, it will send impulses or stimulate these things and release serotonin or acetylcholine to close the gate. So closure of the gate 1, then blocking here 2, blocking at the hypothalamic level 3, and suppressing the cortical influences at the cingulate and the prefrontal cortical levels. So it performs a good. It may be a good thing one has to find out, especially one can try these things in a chronic intractable pain due to terminal illnesses like cancer. Then tractotomy at medulla, midbrain. Say for example, you cut the tracts here, this tract, you cut it. So that means no impulse arising from the pain arising from this side, you can block it. That's one important aspect. Now, what happens? This tract may also damage other sensations coming from other parts of the body. So that is the main issue about these things. Then coming back here, thermocortical strategies. I have just summarized it in simple table here. Thermocortical activity. Thalamus, you go to the particular thalamic area and you destroy the dorsal, medial dorsal nucleus of thalamus. The pain, affective component of the pain, which is going to the cingulate cortex, may be deprived. Or BPL, again, the large segment thalamotomy. If you totally remove the thalamus, you will be ending up with a number of sensory and motor abnormalities. For that reason, you need to be specific, and and you may end up in destroying the thalamus. Means the arousal and awake state is also being hampered. For that reason, this is a experimental stage. You have to be very, very particular. So cauterization of the intralaminar nuclei, somebody have tried experimentally. These are experimentally tried. So these are the arousal state and continuous worrying type of nature they were trying to look at. But however, this is not practical. The limbic system, the people have attempted to remove amygdala because the amygdala is the structure which is for emotions. All the emotional come, whether it is a positive emotion or a negative emotions, no emotion, no pain. So that is the type of a thinking the people are having. Amygdala and the hypothalamus are one another connected. So that is again another thing. But it will have several other effects in the individual. Hypophysectomy, especially the pituitary and the pituitary gland. So that will be only hormonal dependent pain that could be relieved. Then there are points where the parietal cortical ablation. What happens? The parietal cortical ablation will abolish the pain sensation, especially the localization and its discrimination. However, the pain is processed. The part of the pain is processed at the thalamic level. Some pain remains, and this thalamic pain is a emotional pain. It is associated with the anterior cingulate cortex and the prefrontal cortex and the insular cortex. For that reason, it will not abolish the effect of the autonomic effects of the pain or emotional or affective components of the pain. So that means it's not a good idea. The cingulate cortex ablation, so maybe it will block the affective components of the pain. Affective means the emotional components which are mediated in response to emotion. So at this point of time, it will not bother the individual. The pain will not bother. Pain perception remains, but he perceives pain, but it will not bother. Same thing happens with the prefrontal lobotomy. It has been practiced earlier, where with the chronic intractable pains, the prefrontal lobotomy was performed to relieve pain. So because the person who undergoes a chronic pain, he only knows what pain is about. So now, when you cut this thing, what happens? He perceives pain, but he does not bother about it. So that means a prefrontal lobotomy is the procedure in which it does not stop the pain, or it does not abolish the pain, but the botheration associated with the pain is lost. So that is what the thermocortical projections. Now, I summarize here in this particular diagram the pathways: the nociceptor, dorsal horn neuron, lateral spinothalamic tract, divided into neo-laterospinothalamic, paleo-laterospinothalamic, reticular spinal projections. So then neo will be relayed in S1, the paleo will be relayed in amygdala, the anterior cingulate cortex, and insular cortex, and hypothalamus. Then treatment protocols at the local level: the cooling, massaging, and application of counter-irritants, and even the anti-inflammatory drugs. I have not mentioned about anti-inflammatory drugs. They will relieve by reducing the inflammation, by reducing the stretch, by reducing the temperature effect. Then the nerve fiber, neurotomy, local anesthetic application, that is the nerve fiber. This is a last resort. Neurotomy is cutting the nerve, is a irreversible one. Local anesthetic may relieve pain temporarily as long as the local anesthetic remains. In the spinal cord, I mentioned about a gate control theory, and I mentioned about the large fibers close the gate, the small fibers open the gate, and these are modulated by the supraspinal descending inputs and other emotional aspects. And this point has been exploited by the acupuncture techniques, transcutaneous electrical stimulation, and by the opiates, the opiate drugs. They would all relieve the pain. And the GABAergic drugs and the anti-glutamatergic and the anti-substance P drugs also relieve the pain. In the medullary and periaqueductal gray, it is the stimulation of the periaqueductal gray may be attempted. So that's one of the things may relieve the pain, especially the chronic intractable pain. thalamus, thalamotomy is performed, but it affects a number of other aspects. So that is why one has to restrict. The cortical level, the parietal cortex, that is gyrectomy, that only abolishes the perception of the pain, but the affective component remains intact. The cingulate cortex, that will cingulate lobot, cortical lobotomy. So in that case, the affective component of the pain is lost. So that means he is not bothered about the pain. Amygdalectomy, of course, that would produce the severe other behavioral abnormalities, and even including the memory-related issues, may not be a wise decision. Hypophyseal lesions only when hormonally dependent things. The prefrontal lobotomy, it is similar to the cingulate cortex. In this case, the patient is not bothered about pain, but the pain perception remains. These are some of the strategies I have mentioned. This is the summary of whatever I have mentioned here in this. Okay, the books, I have taken it from Kendall's textbook of neuroscience, Guyton's a textbook of physiology, and Genong's. Then the articles from Basabam regarding the molecular mechanisms of pain, and the Am et al. They are my major things. And in this